All right, Dr. Friedberg, thanks for coming in tonight. We're going to give everybody just a quick minute to hop in from the waiting room. Let's see. We're filling up now. Once we get going, I'll give you a proper introduction, okay?
Sure.
Did you have a good day at the office?
I survived.
Ugh, one day at a time.
Yeah.
At least it's not Monday anymore, you know?
Yeah. It feels a little bit more like Wednesday, Thursday. We had an early start today.
Ah, yeah. Well, now you got to live just a couple days longer in the week since it's not Wednesday. All right, well, let's go ahead and get started. Hi, everyone. Good evening and welcome. I'm Caitlin Moore with Norris Medical, and I just want to start by saying how excited I am to have you all here tonight. Whether you're already placing implants or just getting started to explore advanced solutions like zygomatic and pterygoid implants, you're absolutely in the right place. Tonight's webinar is all about getting started the right way, understanding when these solutions are truly indicated and how to plan for them, and what clinical considerations really matter when you're thinking about incorporating them into your practice. We're incredibly lucky to have Dr. Friedberg with us tonight. He brings a wealth of experience in full arch rehabilitation and remote anchored solution. He has a really practical and grounded approach to these techniques, which I really think you're going to appreciate. Our goal tonight is simple: to give you clarity, confidence, and a realistic pathway forward, whether that means integrating these implants into your workflow or understanding when not to use them. We'll have time for Q&A at the end, so definitely drop your questions in the chat as we go. Dr. Friedberg, that was your introduction. Off to the races, sir.
Thank you, Caitlin. It's great to be here, and I'm really flattered to be presenting some of my early experiences with zygomatic and pterygoid implants. And I've been in practice for 20 years. I'm a periodontist by training, and I've been doing edentulous arch since I started in practice. And some of the objectives I have for the webinar is to kind of present a more a realistic pathway to incorporate zygomatic and pterygoid implants into your practice. I personally had a lot of misconceptions of what this would look like. It's costly to go do live patient training. And, I was sort of under the impression that after a live patient training, I'd be coming back and being competent to do quad zygos. And after probably the second or third day of my first live patient training, I realized that that was probably an unrealistic expectation. It's a learning curve. It's a process. And I hope to show some cases from early in my practice to illustrate that. Um, and also what I'm hoping to show is some indications for this, especially in the use of the failing all on X cases, and to facilitate immediate function. One of the things I'm also going to kind of show and hopefully will be appreciated is that as I started to incorporate extramaxillary implants, zygomatics, and pterygoids, I started to look critically at my early all-on-4 cases and started to be able to execute some of those cases better. I think some of the all-on-4 failures I had would not have failed had I been doing them now. In other words, learning zygomatic implants and pterygoid implants put me in company that was executing all-on-4, all-on-X cases at a very high level. And so there's an evolution that took place there. And I also hope that in the course of the webinar, you'll pick up on some considerations that you need to take into account if you're going to incorporate this into your practice, such as inventory, anesthesia, and collaborating with other specialists. I wanted to learn zygomatic implants, I guess predominantly because it was probably 80% of my practice is dental implants. And as I saw zygomatic and pterygoid implants, kind of make a resurgence about 5 years ago, I thought it was, important for me to learn about them as well, whether I was going to incorporate them into my practice or not. And I think one of the other two big motivating factors for me was that I wanted to be able to treat my own failures, and with all on four cases. And I also started to see that the nature of the cases that were coming into my office seemed to change. There were more atrophic maxillas for whatever reason, and I wanted some different options to treat them other than sinus grafting. So and I think, finally, just when I was looking at some of the all on four cases I was doing, where I was cramming four implants in between second premolars, maybe first premolars, I wanted to do better. I wanted to just execute cases better. And when I think about some of the principles of edentulous arch surgery, such as maximizing AP spread and having implants engaged in basal bone and high cumulative torque values. And I think that the pterygoids and the zygomatics fall into that. So just a word about training before we get started. There's a lot of training out there. There's much more training available now than when I started. There is didactic courses, both online and in person. There's cadaver courses. There are live patient training, immersive training experiences. And there's also in-office mentoring. And I would tell you that, as you get started with this, the progression I would recommend that I didn't necessarily follow is you start with a didactic course and perhaps a cadaver course prior to doing live patient training. And I'd also ask you to consider what your baseline level of surgical skills are and your comfort level for handling complications. And when it comes to training, there's a lot out there now, and it's harder to vet instructors. And one thing I can say about Norris is that Norris's training platform they have everything, whether it's didactic, cadaver, in a live patient training, and their instructors are vetted. You're getting an expert, and I think that that's important. So my first exposure to zygomatic implants was an over-the-shoulder course put on by a different implant company. It was in New York City with a very prominent oral surgeon. There was about 20 oral surgeons in the 2-day course. I was the lone periodontist. And these are stock photos. This isn't what I saw, but this is kind of what I saw. Okay, I saw these implants that were threaded all the way up to the neck, and these large antrostomies, and the instrumentation was very limited. And at the end of the case, the surgeon turns to me and says, "Hey, what'd you think?" And I said, "That looked really difficult," and it did. It was a large implant, and it didn't look easy. And I walked away thinking, like, this, I don't know if this is for me. I kind of shelved it for a couple of months, but it didn't go away. And I was getting more and more exposure to Norris and their implant, their zygomatic implant. I was seeing it more, and I was being aware of the training they were offering. And it was a bug that I had, especially after seeing this. It was just an itch I wanted to explore further. I had already been doing pterygoid implants for years in my practice with a non-dedicated pterygoid implant. And more about that later. I kind of thought I had that down, that I probably didn't need much more training with that. But I did. After seeing something like this, I went to Brazil for a kind of a Norris course, and spent the 5 days there, and it was an amazing experience. And probably placed, I don't know, was involved with maybe 20 zygomatic implants. And that's kind of when I was there, realizing, geez, am I going to be able to do a quad when I get home? Probably not, but I felt like I should be able to try to do some some singles. And I came home kind of ready to go. So I'm going to show my first case here. This was Sandra, that was referred to my office by a general dentist for upper all on four. She was 79 at the time we did the case. And this is pretty indicative of the type of all on fours that I was doing. there took advantage of all the premaxillary bone that I could, but the implants are not terribly robust. And over here, this is the pterygoid implant. This is how I was doing them for years. It was not a dedicated pterygoid implant. I just kind of knew the anatomy, and I would drill in it, and the outcomes were totally asymmetrical. So this is what I would get a lot, where I'd be able to get the pterygoid on one side, but not on the other. And, she was put in temps, and 4 months later, well, here's just a picture. This is a cross-sectional picture of the pterygoid, just showing the anatomy, that it is possible to place these things, without a dedicated implant and without dedicated instrumentation, but your predictability is going to be much lower. And just while I'm at it, a word about pterygoid implants. A lot of the studies that look at pterygoid implant success rates, any pterygoid implant that doesn't achieve high stability is removed, and the bone is not always there. And if it's there, it's not always of the highest quality. So you'll see these few cases where I may get it on one side or not another, and that's fairly typical. With more experience, my success rate has gone up quite a bit, and with more training, it's gone up. But 4 months later, this is what we had. The upper right tilted implant failed, and I was disappointed, but at the same time, I had a solution. I was excited to rescue this case with the zygomatic implant. So in working the case up, we get these images, and this just one thing I want to point out is the field of view that is necessary to do zygomatic implants. A large field of view. This was an investment that I made, was upgrading my cone beam to a larger field of view to do this. So we're looking here, just evaluating the zygomatic bone. It looks pretty good. The sinus is clear, and on the right side of my screen, just looking at the ostium, evaluating the ostium, which was patent, so it looked good. And I apologize for the quality of my photos, but during perio residency, I must have missed the photography class. This is just the implant. This is the Norris implant with the extramaxillary approach, and this is connective tissue that was rotated around to kind of augment the tissue. And we did place another implant anterior. Again, at the time, I wasn't. I didn't see the utility of the pterygoid implant like I learned to which I eventually found. So we jumped the case, and eventually, well, here, this is the post-op. This is the final, but we did jump the case and put her in a temp. And I apologize, it's a little out of order. And this is just where it ended up. And this was the very first zygo I did in private practice. And when I critique it is the platform of the implant nowadays would be much further posterior usually. This is probably about a second, maybe a first to second premolar. And nowadays I'm typically getting it over to a first molar. I'll show you a case later where I'm at a second molar. And it's a little higher on the zygomatic arch than is ideal. I mean, I'm being very picky now, but I'm trying to show that my first cases, were there's a learning curve here. This was done under conscious sedation. At the time, I was doing all of my all-on-X cases with conscious sedation, and my early zygo cases were being done with my own sedation. This is just the corona slice showing the zygomatic implant, and it's not overextended. The sinus was clear, post-operatively. And this is what things looked like 3 weeks later. Sandra came in with a lot of discomfort and a lot of congestion, and she had some sinusitis after the zygomatic implant, which is a fairly common complication. And so we tried to treat this medically with antibiotics, steroids, and saline rinses. And after a week, it didn't respond. So she's referred to a colleague of mine. I'm very fortunate to have a friend colleague. It's actually my children's stepfather, who's an ear, nose, and throat surgeon, who is very helpful, been very helpful to me over my career. And so this is what procedure looks like. It creates some drainage, and all symptoms resolved. And most importantly, the zygomatic implant was retained. And it was a very illustrative. It was a very good experience, and I learned a lot. That the one of the things that I had to consider was, geez, on the left side that tilted didn't fail. The pterygoid was there, and so I thought, maybe the really made me reevaluate the utility of the pterygoid. But regarding sinusitis is a real risk of zygomatic implants. And there is the need, if you don't collaborate with an ear, nose, and throat, there is a need to have someone in your on your team to help you with these type of problems, and someone who is familiar with zygomatic implants and dental implants. This would not be a situation that I want to send to just a random ear, nose, and throat doctor, and they're seeing an implant that's going from the alveolus up to the zygoma, sometimes very close to the orbit. So it's just a consideration. After this training, though, this was partially when I became aware of that. Listen, despite the fact I had done some didactic training, I'd done some live patient training, I needed some more exposure. I needed some more training. I needed some different opinions. And I also kind of came to the conclusion that, like, hey, listen, how am I going to get enough repetitions? This was warranty work. This was in first 3 months. And, owning my own practice, I have the ability to do this. If you're an associate in an office, I don't know if you can do this. But this is a consideration. How are you going to get your repetitions? And one of the other things that started to become aware of was the value of doing some of these surgeries with a deeper level of anesthesia, with a secured airway with general anesthesia. So the second case I'm going to show, this is Craig. Craig had an upper and lower all on 4. And again, this is done with conscious sedation, and this is pretty indicative of the type of the type of cases I was doing. So when I critique this, the cantilevers on the bottom are kind of excessive, and nowadays we would get implants in the posterior. But typically, when I was doing my own anesthesia for these cases, by the time I was done with the top, it was time to do the bottom. I mean, I was moving quickly, and the patients are starting to obstruct more on the mandible. And sometimes I was making compromises to get these cases done in a reasonable time frame, and to get them done safely. And there's also not utilizing all the bone on the top. That there's this nasal maxillary buttress that these implants barely engage. I didn't have I wasn't utilizing a protocol like I do now, the Patsy protocol. If you're familiar with it, I typically would paste this posterior implant first, and then paste the anterior implants. And there was a lot of real estate here left unused. So I believe it was within 2-3 years that the upper, I believe it was the upper right tilted implant failed. And we can start seeing, interestingly enough, this is an inferior implant product here, that on the lower left, there was the development of this implant ultimately fractured and was replaced, but that's beyond the scope of this presentation. So we corrected this failure with a zygomatic and now a pterygoid. Kind of had gotten a little smarter with how I was doing these things. And this was also rescued with conscious sedation, which explains why I probably didn't do anything on the upper left. And this is now, better placement. The implant is emerging more like the first molar position, very low on the zygomatic arch, and was able to hit the pterygoid. So this is just what Craig looks like. He's given me permission to show this. And, this raises the question, should pterygoids be placed on every all on X? When I was starting, I didn't know if I agree with that. Now I would argue I attempt them on every all on X case. This is now at this point, I had done my zygomatic implant training had taken me to Spain for some cadaver work. It had taken me to Florida for some cadaver work. I had been to Guatemala for some live patient training, as well as Brazil. And so I probably had spent a cumulative 5 to 6 weeks doing nothing but training, zygomatic, pterygoids, extramaxillary implants. Been the community is very generous, so been in offices watching how different clinicians were doing things. And I think one of the biggest changes was doing these cases with the secured airway. Placing the pterygoid implant with conscious sedation is certainly is something you can do. But when you start bringing in a lot of prosthetic components, digital technology, it is very nice to have a secured airway. So whenever possible, it's kind of what we're doing now, unless a patient objects. And what I observed is, as I've done more pterygoid implants, is revisions definitely have decreased. And also it doesn't take long, depending on your market, where if you start doing a fair amount of zygomatic and pterygoid implants, you'll develop a niche. Whether you want it or not is a different story. So speaking of a niche, this is Milton. Milton was referred to me from a general dentist who just didn't know what to do with him. This was pretty early in my career. And he walked in, and this is what he looked like, and he was completely debilitated. He was just he was a dental cripple, and I wasn't going to let him leave my office like this. I really wanted to do the case, so it was a case that we decided to donate. I say donate. He saved for a couple months for all the parts and pieces, and I've regretted it was as expensive as it was for him. But this is the kind of the X-rays of the reformatted CT, and I really wanted to do this for him. And when you look at the CT, the pan here, it looks like there is tremendous amounts of bone, which there is. Unfortunately, when you kind of figure out your reduction plane here, a lot of that bone goes away, and it doesn't always tell you what the quality of that bone is. So we did Milton, and this is the CT after, and I was able on the right side to avoid the zygomatic implant with the pterygoid implant and tilted implant. Okay. This kind of shows it a little better. So here's our pterygoid implant and a tilted implant and two implants in the front. And then the upper left, we couldn't get good stability here. It's really poor bone quality, which explains the absence of the pterygoid implant. So we were able to get this zygomatic implant. Again, this whole case was donated, and early on, your the zygomatic anatomy varies a lot from patient to patient. It's highly variable. So if you're doing all your training in South America, the zygos are going to look different. This guy had a pretty long face. This was a very long zygomatic implant for a posterior inferior implant, and it's just also kind of part of the learning curve. And again, on the bottom, just this shows up. Anyone can see this. These cantilevers are pretty extensive nowadays. We put posterior implants in here, but this is how it worked out for him. And this was the use of a zygomatic implant to facilitate immediate function. He's been doing great. And this is, I was doing a fair amount, for probably the first 20 to 30 cases, discounted cases, giving them away, doing whatever I needed to do to get repetitions. It is one thing to do these cases under supervision where someone can bail you out. It's a whole different thing to go back into your practice or someone else's practice and to do these cases and to run into a problem and to not be able to bail yourself out. So getting the repetitions in your practice, is important, and it can can be a misleading sense of confidence doing this with somebody else watching you. So these early experiences for me were invaluable in gaining some confidence and repetitions in zygomatic implants. This case is Marylu. Marylu was referred to me from Nuvia. This was at the time they weren't doing atrophic cases. They didn't have that ability. I know for a fact they do now. So this case now represents much further along in my learning curve. And what I'm hoping can be appreciated from this is just how I learned to avoid placing zygomatic implants and how the quality of my all-on-X cases, improved. So there is a previous history of an orbital rim fracture, which really doesn't play much of a role here, in this case. But this is what Marylu looked like. Been in dentures for decades. Just wanted to get out of these dentures. Kind of what real thin maxilla. But when I work these cases up, typically look for, not necessarily first, but the nasal maxillary buttress is really where I'm looking. So despite this being pretty thin at the crest, there was a pretty good nasal maxillary buttress to engage. This is on the left side. And then this is just on the right side. There was some decent bone. So I was pretty confident we could do this without zygomatic implants. And this is what we did. We kind of did there. I wouldn't say these are palatal approach, but they're somewhat erring on the side of the palate. These are now 20 plus millimeter implants. We're hitting pterygoids. This is what the case looks like on pan. And you just get a sense from looking at this that this is it looks a lot different than those early all-on-4s. We have implants in basal bone. They're much more robust implants that are present, taking full advantage of the bone without cramming, implants in from second premolar. So, nowadays I think cases like this are much cooler than zygomatic implants. Zygomatic implants are not without risks, and once you start using up that hardware, that real estate, you can't really go back. Just some X-rays showing, utilizing all the bone around the nasal maxillary buttress. I think these are the temps. I think the midline's a little off. I'm sorry. Again, my photography is I'm blown away by the quality of photography out there, and it's not part of my skill set. So this is the final case I'm going to show is Janine. And this is now much more indicative of what we're doing now. And I also should point out that the last case I show was done with general anesthesia, and that does open up some options for you. So Janine's one of these patients who comes in looking like this the day of the surgery. This obviously is a scan marker, but what type of patient who's saying, I want to look like this, so, a lot of bone loss, and she wanted to get out of these partial dentures. And this is just an intraoperative photo showing kind of what things look like. And what I recall from this case was the bone was very, very soft. It was not easy to get 4 implants stable. The pterygoids were mush, and I'll show you what that looked like. This tilted didn't torque, and the zygos, it was not so easy. It took me 1 or 2 attempts to kind of get to find some good bone to stabilize these in. But just looking at the prosthesis, this case probably represents maybe I'd say at least 70, 80 zygomatic implants. Where now I'm able to consistently put the platform, in a first molar or even more distal, if indicated. That was not really part of my skill set, early on, and getting mastery over access hole placement. And here's just what it looks like in radiographs, where there's, and these are, and in fairness too, these zygos are huge, and we don't always have this type of anatomy, but despite it being huge, it wasn't the easiest to find good stability. What I'm trying to show here with this photograph, though, is utilizing the anterior nasal crest and how these implants, the anterior implants, kind of crisscross to get good spread and good stability, and leaving a lot of real estate open for revisions. So here's this implants, one in front of the other, and these are some of the advanced techniques that you will more likely you will learn just by pursuing all on X, more all on X training, either in conjunction with zygomatic or pterygoid training, or perhaps even before you're trying to do zygomatic and pterygoids, you should consider learning some of these techniques. And as I said, we don't put the same type of cantilevers on the mandible anymore. Try to get an implant in the posterior. So these are just cross-sectional images. These implants are completely out of the. They're not just they're extra maxillary, extra sinus, and that's what Janine looks like. And I believe that concludes the presentation.
It sounds like I'm getting summoned back, Doc. That was fantastic. It looks like we have some questions in the chat, so I'm going to hold you just a little bit longer, and that way we can work through some of the questions that I've gotten via text message, in the chat, and then on our sidebar conversations from some of my teammates, okay? All
Sure.
right. So one of the first things that you brought up was complications. So, what complications should clinicians expect early in their learning curve?
Well, I think that there's no shortage of complications that you can talk about. I think the two big ones that are always discussed is sinusitis, and it can be late. So you may not see sinusitis till years later. And then I think the second most common one is soft tissue, dehiscences from the zygomatic implants. And it's typically a balance. You place the implant deeper into the alveolus, you are going to minimize the risk of soft tissue recession, but you may be closer into the sinus and maximize the risk of sinusitis. I think that one of the other big problems, related to sinus problems, is oral antral fistulas, which can be very, very difficult to manage, and is more likely to be present if your preparation is kind of wide. The pictures I showed here, the zygomatic implant kind of fits into the slot like a hot dog in a bun, and even with that, we had some sinusitis. So I think, in addition to oral antral fistulas, sinusitis, it can be acute, it can be chronic, it can be years later. Soft tissue dehiscences, oral cutaneous fistulas if the implant is overextended, and even if it isn't overextended, if some debris is left under the flap, it may take years to necrose in an oral cutaneous fistula, which obviously would be pretty disturbing to you and the patient. When you start talking about the quad, there's a whole other set of complications where orbital involvement and things like that, oral nasal communications, and I think that's a good point that the quad is going to have a whole new set of complications that the single posterior inferior may not have. There's plenty that can happen with that as well, but I would say those are some. And then I think the other thing is that as you start progressing up the maxilla, this way, the vessels get bigger. There is more of an opportunity for bleeds. And unless you're comfortable managing a bleed, it could be an issue. The infraorbital nerve paresthesias are very common from just stretching the flap. And to the best of my knowledge, it hasn't been reported, but right under the tissue here is pretty thin, and there is facial nerve that is running up there. And to the best of my knowledge, there's never been a report of a facial nerve injury from zygomatic implants yet.
Okay, so we want to talk about prevention now, but just a little side comment, your hot dog in the bun definitely made the chat a little happy on that comparison. So thank you for that analogy, because I like it's like a dad joke. It just makes everything a little lighter. So how do you prevent soft tissue help me with this word, Doc, dehiscence
Dehiscence.
after that one? Thank you with my southern accent. After zygomatic implant therapy.
The way I was taught to prevent it, well, was first and foremost to make sure that the implant is placed far enough into the alveolus. Um, that is one. Different implant designs have been out there to try to minimize that, but the idea is that pressure on the soft tissue can cause some recession. And the other one of the other factors there is that if there's some these zygomatic implants, when you percuss them, they don't percuss like a root form implant. There is some mobility, there is some flex to them, and they're gonna flex a lot more depending on how well placed it is, if it's supported by bone. So if there's movement, that can also predispose to some recession. So proper placement um, is important. I think that in certain cases where it's very atrophic, the pterygoid implant can help provide some support and prevent some bending. May prevent it. And then there's various soft tissue procedures that are performed at the time of zygomatic implant placement, which is buccal fat pad, which we do a fair amount, rotated connective tissues, incision design. And then I think something that gets overlooked a lot, but something that I try to do, is that trying to edentulate patients and get some more tissue. And the posterior, I think, can really. There's some schools that do that, doing these things around fresh extraction sockets, around diseased teeth. Sometimes there's limited tissue to begin with, and that can oftentimes predispose to recession. So where possible, if you can get some, if you're starting with healthy soft tissue and you can make your incision in a strategic place to put better tissue on the facial of that zygomatic implant, that can help. And then I think sometimes we make decisions, or what kind of complications are we willing to work with. Every case is different, highly variable anatomy. Sometimes perhaps it's preferable with certain implant designs, such as Norris's, to get some soft tissue dehiscence rather than having sinus involvement. It's kind of it's a discussion point, but those are a few of the things that we try to do to prevent it.
Thank you for the shout out, Doc. I can't help but get excited. We have a follow-up to that question is do you utilize CO2 lasers to control it or to help maintain controlled health? Excellent and helpful answer. Thank you.
So lasers, I'm a laser. I do have a laser. I do not have a CO2 laser. And I suppose the question is asking, how do we treat the dehiscences when they happen? Um, and so for me, a CO2 laser is not part of my practice, and nor do I manage zygomatic implants with the laser that I have. For most of the dehiscences that I've seen, they are pretty maintainable with the polished collars, for lack of better verbiage right now. It recedes, so far they seem to stay pretty healthy. I think that so I haven't, so I'm not using a laser. It's just a matter of oral hygiene and trying not to do much with it.
Awesome. Well, thank you for that one. So over here I have, what is your tolerance for the zygote protruding at the exit point? When do you cut off the apex versus place a shorter zygote versus leave it?
Oh, that's a great question. Um, so I have very limited tolerance for overextended. I kind of use an instrument. I typically will take like a molt curette, number 4 molt, and drag it. And if I feel like any catch, I will plasty off the apex. But again, one of the things that I've just learned is that some, so a rule would be probably about a millimeter, and some people will tolerate more, some people will tolerate less. Sometimes they don't perforate through the cortex at all with the implant. But sometimes it is necessary to overextend that implant a little bit to get stability. So if it's more, for me, more than about a millimeter, more than if my curette is catching it, then I take a burr up there and plasty off the apex.
Awesome. Ooh, I'm getting bubbles in every direction, so I'm going to pick the middle one while these two load. What are the biggest mistakes you see when clinicians try to jump into these cases too early on? I'm assuming in their education development.
I haven't seen that many of mistakes. I've been at live patient training courses where um, I think that some of the attendees have had limited surgical, experiences, and I think that what they're probably not getting much out of the course. Um, I think, prior to doing zygomatic implants, I've been doing sinus lifts for, over 20 years and had sinusitis, and dealing with that. And, had done, doing all on edentulous arch implant cases for, almost 20 years. And and for me, getting involved in zygomatic implants was not something I took lightly. It was a matter of it was, I mean, I say not taken lightly, meaning it was not one course. I went to that I did a week in Brazil. Not to repeat myself, but multiple didactic courses, and speaking to multiple people to try to find like what my truth would be. So I think that a lot of the biggest mistake, I think what I would say in answer to that is that I think with a little bit of experience, and a little bit of experience can come from a live patient course. Um, there can be a false sense of confidence about what you can achieve, and what you can do, and a little overestimating one's skills.
Yes, and then implementing it back in your practice can always be a little bit difficult from having that over the shoulder mentorship that you kind of get at these life patients, and not even kind of, we're there all up in it. So now we're gonna go to your go-to bailout strategy because I like to keep you on your toes. So what's your go-to bailout strategy intra holy guacamole, Batman, intraoperatively if the trajectory is off?
That's a good question.
They're hitting
So,
me with some good ones tonight.
um, in other words, I believe the question is, if during preparation, I find that the trajectory is off, how do I handle that?
Yes.
It's a great question. So, part of what part of the protocol here, at least with Norris's protocol, is this barrel burr. And it is, it's a brilliant design. It's a brilliant technique. It's not the only company that has that barrel burr to prepare the channel. And for me, I early on I found that if I was off with that, I had already left a big footprint. So I don't use the barrel burr. I start off with a round burr, and it may be slower, it takes longer, but I try to create a smaller footprint. I use the barrel. First thing I use is pencil. Actually, the answer to the question starts with preparation. I do all of these cases with model surgery, so I do print 3D models. I don't see any reason not to. I don't do as many repetitions, but I will get out the models ahead of time and try to identify some landmarks and put the models out on the tray. And then when I expose the case, I use pencil to mark my trajectory, to mark all the different points. And then I start with a small round burr. And I kind of draw the channel with that. This is before I've even entered the zygomatic entry point. So prior to committing with a barrel burr, I've used a round burr, and that allows you to make changes much easier. You can kind of open it up a little bit superiorly as you're entering the zygomatic, your zygo entry point, and at the crest. And that's you try to prevent it. That's the best answer I can give you, is that if you find that you're off, um, you try to prevent it. And you prevent it, at least for me, it's by using a very, using an instrument that leaves a small footprint. And so I use a round burr. And then when I've lined everything up and I'm confident to where it is based upon the intraoperative findings, my preparation, and the radiographs, then I will use a barrel burr to kind of smooth things out. But that's how I prevent it, is that if I see that I don't overly commit with the barrel burr.
Okay, perfect. So now we're talking about planning, and I've had a lot of conversation about prosthetically driven planning. So when do you personally use guided surgery versus freehand?
I don't use guided surgery.
No guided
Um,
surgery.
I've never done a guided edentulous arch surgery for FP3 type of prostheses. I have never done a guided zygomatic implant, and I've never done a guided pterygoid implant. I don't. I just, it's not part of what I do. I want to see what I'm doing. I want irrigation, and it's just not part of what I do for FP3 type of prostheses. And I would
Fantastic.
argue, I'd argue, listen, there's multiple ways of doing things, and some people have the technology. Some doctors I've spoken to have technology, where they're very comfortable with the technology and how to use it, and are using things off label. And there's the easy guide out there that people are using. It's just not part of what I do. I didn't grow up with a lot of this technology in practice, so it's not part of what I do, and I'm not the person to ask about guided, um, zygomatic or all on X type of surgery. It's just not what I do.
No, that's totally fair because now the group chats are going hashtag freehand gang all the way, Doc. So there's a lot of people sharing those opinions. So how are you structuring team training, your assistant to the lab to digital for these types of cases?
That's a lot of on the job training. Okay. That I think with regards to that the consideration is that, uh, I'm fortunate in that we keep a pretty large implant inventory. But there was a time when, I didn't have the volume, and, you'd have like 20 to 40 implants around. If you did an edentulous arch case, you order a bunch of implants and return what you don't need. But I think the main thing for staff when it comes to doing zygomatic and pterygoid implants, you need an extensive inventory. I mean, you need every size, multiples of the sizes, and multiple selections of multi units. And so a lot of the time with the team is spent making sure they understand this inventory needs to be maintained. Um, in terms of like training the team for zygomatic implants, a lot of that is like they need to understand that sometimes like there's some nuances that with retracting and an extra source of irrigation. You have a long implant, the irrigation doesn't get up there, and the team assistants need to know to kind of irrigate a little bit more up there. And they also sometimes they like to see. And so sometimes, it's sometimes only one person can see, and they have to be kind of content to like, to retract blindly for a while. And then you could kind of show them what you're doing. But I think, that's about the extent of it for training for me. I'm sure there's something I'm missing.
No, I could tell you from being one of the ones who likes to see the lights that you guys wear bonk pretty hard. So, when training your team members, make sure you take their lights into consideration. So when you're trying to look, you don't whack heads. And then a follow-up question to that, would you say it's easier to have someone come in to help train and mentor through your first case as a new doctor placing?
I think that that's the one. I have never had that. I never had in-office mentoring. Um, I think it would be a great thing to do in the sense that you are, I think it's a wise thing to do. I think that the progression that and I made a mistake, that I did an over-the-shoulder course, and then I did a live course. And then after I did the live course, I did some cadaver courses. Okay. And after I did the live course, I was already placing them, just not as comfortably. And then after all that, I went back and did another live course, and that was kind of the nature of my training. I think, now if I were going to recommend like a pathway, it would be do a didactic course. If you can do a cadaver course, that would be great. And perhaps after that, consider a live patient course. And then maybe even another cadaver course. And then after you do live patient, for to bring somebody in to do some in-office mentoring, I think would be a good thing. Um, I think that the one of the benefits of these live patient courses, provided they're put on by reputable sources and with vetted instructors, is that you're able to get a lot of exposure, some immersion. Um, but I think that also having somebody come into your office, looking at your setup, looking at how your room is set up, that could be beneficial as well.
That's very insightful, Doc. Thanks so much. Just because, speaking from Norris, we want to make sure that we're helping build these communities so that way doctors feel support from all aspects. So having that community and having that support from a team kind of is essentially what we're here for. So that's fantastic to hear that that's what you're recommending. So I'm going to take two more questions and then I'll let you have your evening for the night. So, what are the biggest indicators of choosing when and when not to place pterygoid implants during an all on X case?
I think there's more, probably there's, let's talk about contraindicators. For me, a contraindication would be a history of orthognathic surgery. For me, that would be one that I would be approaching very cautiously. The other one would be if the anatomy, if there is going to be an anatomically driven, so that if there is no tuberosity, if it's like sinus all the way back there, I probably am not going to attempt to do it because I don't want to have to deal with a possible oral antral communication. Although I have done trans sinus ones, so it's not an absolute one. I think for me, the history of orthognathic surgery would be one that I would approach with extreme caution. The other one would be limited opening, if they don't open, and then I think you have to consider what's in the mandible. If it's second molars in the mandible, you could place it, but you better place it in a manner that's restorable. And then I think the others are just going to be, relative contraindications in terms of anatomy. That's kind of what I can think of. If preoperatively there looks like there's just no bone back there, I don't necessarily want to waste tons of time back there. I may give it one try. In terms of the indications are always there to maximize AP spread, to increase cumulative torque value, to take stress off of your tilted implant or your zygomatic implant. Those are indications.
Okay, so then there's one follow-up question to that, and then I'll give our closeout. Do you ever use Botox masseter to help with the patient's opening? So will you treat their opening first?
I've never used Botox to treat patients opening. But I do use it increasingly to manage parafunction, as part of comprehensive care with these type of cases and other cases. So I do use it. If for the opening, with limited opening, this is where more of these cases are done with general anesthesia, and that is very helpful. Um, I have a case Thursday. The patient's insisting upon conscious sedation, and she's told you may only get 4 implants. So she may or may not get pterygoids, and if she does get pterygoids, she may not get. I may not be able to restore them, that day. So no, I use Botox. I use Botox more to manage parafunction, not to try to increase, opening.
Well, thank you, Doc. All right, everyone. So we'll go ahead and start wrapping things up here. Dr. Friedberg, thank you again for sharing your time and your expertise with us. It was an incredible overview and such a valuable perspective on how to approach these advanced implant solutions responsibly and predictably. For those of you who are interested in taking the next step, whether it's case support, planning guidance, or hands-on training, that's exactly what we're here for at Norris. We're more than happy to support you through that journey. So if you have any follow-up questions or want to connect with the team, don't hesitate to reach out. We love continuing this conversation. Thank you all again, and thank you for spending your evening with us. Thanks, everybody. Bye.
Thank you.